Okay, sir. So we can start. So, good evening. My name is Ehsan, and I'm the Surgical Neuro-Oncology Fellow at the Afghan University Hospital and member of Pakistan Society of Neuro-Oncology, PASNO. On behalf of PASNO, I welcome you all to this session. PASNO is organizing the Neuro-Oncology webinar series, and each session in this webinar series will be an hour long and held on alternate Saturdays. During the talk of our guest speaker, all attendees will be muted to enable the speaker to present without any interruption. Questions can be submitted in the chat box and will be answered once the presenter has finished their talk. Attendees can also raise their hands for questions. We will unmute them to speak. This session will be recorded and the link will be shared on the PASNO website. The speaker will take 30 minutes for the topic presentation, and after that, there will be an open discussion between our esteemed speaker, Dr. Rashid Juma, Dr. Athar Inam, Dr. Umar Chauhan, and the attendees. The topic of today's session is the role of palliative and ablative radiotherapy for spinal metastases. And today we are honored to have Dr. Gregory Gan. Dr. Gregory Gan is a physician scientist and assistant professor at the University of Kansas Medical Center. Dr. Gan is certified by American Board of Radiology with a sub-certification in radiation oncology. He graduated medical school with honors from the University of Pittsburgh School of Medicine and completed his residency and research fellowship at the University of Colorado Anschutz Cancer Center. Dr. Gan's research focuses on epithelial to mesenchymal transition and how it regulates the development of cancer stem cells, tumor metastasis, the tumor microenvironment, and therapeutic resistance. His long-term research goal is to better understand the molecular drivers responsible for cancer metastases, as well as develop novel therapeutics to enhance tumor sensitivity to radiation and systemic therapy. Thank you so much, Dr. Gan, for joining us today. The floor is yours, sir.
Thank you very much for the very, very kind introduction. I do want to thank PASNO for this opportunity, as well as to my colleague, Dr. Mohammed Chauhan, as well for the external invitation. So, why don't we get started and everything? These are my disclosures, just for full openness, but nothing that really pertains so much to this talk. Just a brief outline of kind of where I would like to go. I'll initially provide a little bit of information on the role of palliative radiation for oncologic emergencies, just very broadly in general, and then focusing really on palliation to bone mets, spinal mets, which much of the literature kind of encompasses. As well, then we'll transition over to the role of ablative radiotherapy to the spine, and then provide a couple case management examples of how a multidisciplinary approach between the neurosurgeon, interventional radiology, radiation oncology, and then the medical oncologist may actually all play that role together. So with this, how can we use radiation therapy to try and fit into the palliative care setting? So many of these things that I'm sure all of you are very familiar with in the hospital. Various teams get activated and everything once certain things are discovered between bone pain, brain metastasis, airway compromise, vaginal bleeding, or superior vena cava syndrome, and cord compression. And oftentimes the radiation oncologist is often contacted in addition to many other critical support teams within the hospital, between the neurosurgeon or the surgeon, medical oncology teams, interventionalists, to try and help with managing these critical situations. But there's a bit of a balancing act when you first discover a cancer patient, or when you have a long-term existing patient. Obviously, there's a continuum where individuals are initially diagnosed. These individuals may have good performance statuses and are anticipated to have a very long lifespan, on the opposite end of that spectrum, you have patients who have very advanced disease, poor performance status, short lifespan, or are approaching end of life. And so, the radiation oncologist, plays a role in much of this cancer continuum, where they can utilize radiation treatment to try and help with benefit of the patient. In these situations where patients are maybe initially diagnosed, you're trying to integrate palliative radiation treatment as part of the definitive care. And so the goal is to palliate them as quickly as possible and then get them to their definitive treatment. In contrast to this, when you have patients who are towards the end of life, or the disease, or maybe succumbing to their disease, again, palliative radiation treatment can be utilized to try and help transition them to hospice or their end of life care. So palliative radiation treatment, if you want to consider it, oftentimes at the end of life, the radiation oncologist needs to try and keep in mind, obviously the patient circumstances, trying to minimize costs and suffering, focus on the short-term benefits, not necessarily focus on potentially the long-term side effects, particularly in the case of spine, things like myelopathy, try and keep in mind everything that time's precious, and to try and find the shortest possible treatment and efficient resource utilization. Obviously, there are many things that can be done to try and help manage this, whether it be for pain relief, particularly for bone or nerve compression of the spine or to joints, control of bleeding, control of a fungating or ulcerating tumor, relief of an obstruction, particularly in the case of, say, something like airway compression, and to try and prevent morbidity and kind of ease that pain and suffering. So types of radiation treatment that can be used to deliver our treatments, they run the gamut. Obviously, some people have the newest technology, and other people have technology that's been around for decades. And so, it's I think part of what makes radiation treatment as effective is that some, even just the simplest treatment techniques can still be very, very effective at palliating and taking care of pain, but also just delivering important treatment, to try and help with a decompression of a tumor, particularly in a very critical area. So when I talk about types of radiation treatment delivery, you have traditional, how we've been doing it for decades upon decades upon decades since the start of radiation treatment, which is 2D radiation therapy. And then what has been seen, at least in the United States, in the Western world, 3D conformal radiation treatment, where you are now placing a volume and then using multiple beams. Intensity modulated radiation treatment, where now you are actively having a computer program or model, essentially what we call inverse plan a treatment, and actually kind of utilize advanced computing technology to try and help with modulating your radiation treatment, along with more advanced technology that is actually placed within the linear accelerator, or LINAC. And then there's obviously stereotactic radiosurgery, which the neurosurgical community is very familiar with, and how we're using pinpoint focused radiation treatment to ablate brain metastases, as well as benign lesions that are non-cancerous, but may be causing problems, such as in the case of AVMs or trigeminal neuralgias. And then stereotactic body radiotherapy, where we utilize, again, similar concepts with SRS, but are using pinpoint focused treatments in an extracranial fashion. So again, here's some pictographical examples of this, how we can treat bony metastases, particularly within the lumbar spine, where we are using essentially X-ray radiographs and essentially wax pencils and everything like that to actually denote our radiation field, where then our team will actually cut out the appropriate necessary blocks, and then you're essentially giving treatments, one beam, 2 beams, in a very non-specific fashion, where you're essentially passing front to back, or what we call anterior anterior beams, or APPA. Again, very historical, very common way, and still being done to this day. In this situation here, rather than use an actual X-ray, we actually we'll use a CT scan. So kind of cheating how instead of what we've done before in the past. So, but still nonetheless effective. And then you have 3D conformal, again, another pictogram and everything, where now we're utilizing anatomy and taking this into consideration, contouring out our specific targets. And from this, utilizing multiple beam angles to try and help with shaping our fields, and then trying to focus it in on the specific area that we're interested in. In the intensity modulated radiation therapy era, we're using a combination of CT-based anatomy, contouring in our specific target of interest, utilizing advanced computing, and where we do inverse planning, as well as uh, um, multi-leaf collimators to help us with shaping our radiation fields. And in doing so, it enables to dose escalate to the target itself, while at the same time reducing dose to all normal tissue structures. And with this, I think this difference is, as you can imagine, can be quite striking. We have examples here of 2D radiotherapy, 3D radiotherapy, and IMRT, or intensity modulated radiation therapy. The benefit of this with doing 2D, obviously, if you have an emergency in the hospital, you can pretty much put the patient, simulate, or get a scan, and then from there, not really do anything fancy, put 1 or 2 beams on, and immediately treat that target, which is this thing noted right here, okay, for nasopharynx cancer. Now, if you use 3D, obviously you can shape it a little bit more, spare a little bit more tissue. And then when you're using intensity modulated radiation therapy, this really requires more time. It's a little bit slower to plan. You need to do a lot of physics quality assurance checks to make sure that you are able to deliver this safely. And so oftentimes this is not something that you can do very rapidly in the hospital. And very similar to stereotactic body radiotherapy or stereotactic radiosurgery, you need time for your physicists and dosimeters to plan this, QA it, check it. The physician is also doing all those things. So surely not something you could turn around in 2 hours like you could with a 2D plan. But the potential benefits, if you are able to wait, are there, where you can really escalate your radiation dose to target your tumor while sparing and minimizing a lot of normal structures such as oral cavity, carotids, as well as spinal cord. And with this, hopefully with less side effects as well. Finally, in everything, stereotactic radiosurgery and SBRT, which I'll show some more examples of SBRT later in this talk, but really pinpoint focused radiation treatment. This audience really does not need introduction to this, but just to kind of highlight the benefits of SRS, very, very hyperconformal treatments with very sharp dose gradients where you can deliver anywhere from 20 to 25 to 30 gray, and then within 5 to 7 millimeters, this drops off to almost half that dose, if not more, as a very strong advantage of this type of treatment, where you can give very ablative doses in 1, 2, or 3 fractions. Oftentimes, this requires multiple beam angles where they're coming from non-coplanar and entering the patient's body at different angles, where again, the rest of the body doesn't really experience that dose of radiation treatment, but where they all converge allows for very, very intense radiation treatment, an ablative treatment. So why don't we move into a little bit of the literature supporting the use of palliative radiation treatment, just take it from this more global perspective right into bone. And particularly a lot of these studies that I'm highlighting, even though they were looked at for all bone metastases, quite a few of them also were utilized for treatment of, say, spine, cervical, thoracic, lumbar, and sacral. So a lot of this is extrapolated to how we would manage an uncomplicated bone metastases. So key questions in terms of the patient management: obviously the degree and location of the pain, histology, systemic therapy options, surgical stabilization that is necessary, such as if this was in the femoral head, or if they were in the spine and you needed to place a specialized device for cage or for separation surgery. Life expectancy, performance status, obviously an important thing, as well as degree of narcotic and steroid needs. So again, R2G 9714, an American study, or North American study, I should say, by Hartzell in 1999. This was a phase 3 randomized trial, looked at almost 1,000 patients with primarily breast and prostate cancer who had bony disease, randomized either 8 gray or 30 gray in 10 fractions. So a single fraction versus 10 fractions of radiation. They looked at patient-reported responses, and from this, they really saw that in terms of the 3-month pain control, really no difference between that 8 gray versus the 30 gray fraction. And then when you looked at how often these patients need to be retreated, oftentimes and everything, those individuals that received the single fraction dose required more retreatment in comparison to those who had the 10 fraction course. There was a question that was raised: is this really due to physician bias versus a true actual need? Like, did they really need to have a second course of radiation? And that's something that was really, potentially a question. But along with that too, as you can guess, A single fraction, patients can usually get away with most anything. But that said, those who had multi-fraction course, the 10 fractions, did have almost twice as much acute toxicity. So that said, when you actually kind of look, you're going to see a very similar theme with the Dutch bone met trial, again by Steenlin in 1999. Again, another randomized phase 3 trial, almost 1,200 patients in this, randomized again 8 gray times 1 versus 24 gray and 6 fractions. As you can see, there was an overall 71% response rate, 4-fold higher rates of retreatment in the single fraction arm. But with this, if you actually look at pain relief for both, oftentimes you could see within weeks of randomization a significant improvement from essentially where you started to where you ended, but really no difference between either arm. And it's similar to that when you actually look at the time to response, roughly about 8 to 10 weeks, you saw this overall response where a majority of your patients actually experienced some form of relief from their pain. Finally, with the bone pain trial working group party, again, British UK-based study, Royal Marsden published in 1999. Again, another randomized phase 3, almost 800 patients, looked at breast, prostate, but they did look at many other sites, including lung, colorectal, thyroid. Again, randomized 3 different courses, 8, 20, 30, 8, 20 gray, 30 gray. And what they ended up looking at was about 70% of the patients had some form of pain relief, and really no difference between any 3 of these arms, with 50% of these patients achieving some kind of complete response to their pain, which is great. Rates of retreatment, obviously, as you can see, very common theme, twice as much in the single fraction arm compared to those that get multi-fraction. So again, similar curves as I've shown you before. Many of these patients experience their time to pain relief. Usually within 8 weeks, you've pretty much plateaued, but most of this you can experience in the first 1 to 3 weeks. In terms of those who have a time to complete response, they're pain complete elimination, again, about 60% of these patients, and usually this is occurring somewhere around that. It plateaus roughly around like 6-ish or so weeks, which is, again, fairly effective, whether or not you're treating bone metastasis in the thigh to something in the spine. Finally, and everything like that, what has been more widely adopted here in the US is the use of radium-223. Again, landmark study and everything like that, New England Journal of Medicine. Almost, again, 900 plus patients looked at overall survival, primarily prostate cancer, but this is now being expanded and looked at in other disease sites, particularly those within breast cancer. And again, has to have primarily metastatic bony disease without any soft tissue, component. Again, primary kind of overall survival. Secondary was time to first skeletal events and biochemical progression. Study was terminated early because of efficacy, as you can see from this nuclear medicine scintigraphy. This individual has widespread bony prostate disease. The way that this compound works is that radium-223 becomes incorporated within the bony matrix. Prostate cancer sends various growth factors, activates the osteoclast to eat and destroy bone, and along with that, they secrete factors back. As the radium-223 intercalates, it has a very limited particle range, and because of this, kills the osteoclasts, and then in doing so, limits bone reabsorption, and in doing so, also simultaneously chokes off the tumor. With this, they demonstrated a 3+ month improvement in overall survival with a hazard ratio of 0.7. So kind of like the ultra summary of many of these trials, as well as the 19 others that kind of look at the role of palliative radiation treatment for external beam. Many of these trials utilize treatment of bone to multiple sites, including the spine, and really much of this utilizes 2D radiotherapy techniques. Short or long course fractions can really improve bone pain control at 1 to 3 months. But you did observe higher rates of bone retreatment with the single fraction course compared to the multi-fraction course. So how do we integrate this care and everything? And I think this is where I think time, value, patient preference, as well as kind of end of life discussions versus is this a definitive course? So end-of-life hospice patients, poor performance status, short life expectancy. Oftentimes, we employ this 8 grade times 1, especially at my facility, but I think you'll see this done at many other places around the United States and probably Europe and Asia. In contrast, for those patients who have, who have, early stage disease, good performance status, expected of a very long lifespan, and you are preparing to do more definitive or curative intent treatment, doing the multi-fraction course obviously will provide more durable disease control and is likely to be superior in contrast to the single fraction course. So again, for these patients, particularly those who are just starting lung cancer treatment, prostate, breast, we tend to use these multi-fraction courses. So kind of focusing in on some of the specific spine questions. I'm going to go with a very classic study, kind of extrapolate again from some of the existing studies that we just discussed, and we'll kind of talk with a little bit more focus on the classic Patchell study, which again this audience does not need any introduction to, as well as the Chang radiosurgery paper. And so with this, for a presentation of spinal cord compression, things that you want to try and keep in mind is pain syndrome. Is it due to biologic? Is it mechanical? Is it radiculopathy? And the thing that I will say, but it's important for the radiation oncologist when they're assessing this patient, and looking at some of these factors, if it's biologic, because the tumor itself is secreting cytokines, causing localized irritation, stress on the local microenvironment, this is something we can obviously take care of, because we can kill the tumor and then stop the production of these inflammatory cytokines and thereby improve pain. If it's something mechanical, where the bone itself is unstable, it's compressed down, it is now actually crushing or pressing on nerves. The radiation oncologist cannot fix this. This is something that is in the realm of surgeon, and we need our surgical colleagues' input to try and assess whether or not it's appropriate and safe to actually perform surgery. In the case of things, again, with radiculopathy, again, another important thing. The radiation oncologist cannot fix radiculopathy. We can obviously prevent the cancer that may be compressing or squeezing along that area, but along with that, we also have to recognize, the limitations of what radiation is able to do. And again, this is something where we need to turn to our neurosurgical colleagues or orthopedic spine colleagues, for assistance to try and help, in these situations where this is more so a structural issue. And then, of course, the dreaded myelopathy, where, again, radiation treatment can help with reduction of the overall tumor burden. But if the patient has experienced frank myelopathy due to these mechanical issues, again, this is something that cannot be managed with radiation solely, and is best served in a multidisciplinary approach with our neurosurgical colleagues. Other things that we need to try and take into consideration when we ourselves are called to the floors to see these patients, the histology. Is it radiation sensitive versus radiation resistant? What is the prognosis of these patients? Are we looking at them with like a single bone metastasis, or are we talking about widespread metastatic disease without any options? Other symptoms that can force our hands one way or the other, obviously pain, ambulation status, neurologic sequelae. Are they having fecal incontinence or urinary retention incontinence? Obviously, this sequencing of some of these symptoms will direct us with what is the potentially best next course of treatment. Obviously, the duration of their spine pain. This is something where, and I would say beyond just durations of spine pain, but also their symptoms. If a patient comes to us with essentially already loss weakness and loss of overall function because of a mass that has been compressing the cord for over 6 months, even 3 months, we may not be able to reverse any of that because the damage may be done. Versus somebody who was previously playing golf or walking, and then they come in, 24 hours later with sudden weakness of their, a foot drop. These are things that can potentially be reversed and changed. And again, physical exam obviously is very important for any radiation oncologist or member of the neuro-oncology team to perform. Neuro-access imaging is obviously extremely important because obviously if you have a lesion at one spinal level, there could be disease at multiple spinal levels. And so it's important whenever possible to try and get a cervical, thoracic, and lumbosacral MRI total spine if at all possible to assess. In addition to this, as I've highlighted the importance of this, before any radiation treatment should be delivered, we need to be talking with our neurosurgery and or ortho spine colleagues, regarding their appropriateness for surgery. If there are questions about spinal stability, and then mechanical cord compression, again, the radiation oncologist can't fix this. We can maybe palliate some of the symptoms, but we will not fix this type of problem, and we need the input of our surgeons. And then finally, about the symptomaticness of their disease, whether or not they're on steroids, pain medications, and again, oftentimes what we tend to use here, we will sometimes bolus a 10 milligram dose and then go with 4 to 6 mgs IV or PO, but oftentimes I will see here at my institution now, and while we were in New Mexico, when I was working with Dr. Chohan, we'd oftentimes start our patients on these 4 milligram of IV or PO Decadron, when these patients would present to us in the emergency departments. So the clinical conundrum, as I've kind of highlighted, irradiate or not to irradiate, and this timing of when to get surgery involved. Obviously, for lesions that are painful, bony metastases where it's within the spinal axis but without any evidence of cord compression, you can consider conventional fractional radiotherapy. And back in the day, 20, 30 years ago, this was all we had, and so it was very effective. It did its trick. It helped many of our patients decrease their reliance on narcotics or steroids. However, when you actually have mechanical instability, and again, I haven't gone into all the different nomograms and everything that are affiliated with this kind of assessment of spinal cord stability. This I know you will get Dr. Bilski from Memorial Sloan Kettering, so I'm sure he will probably go into the description of the spinal instability score in probably much greater detail. But just to highlight, if we are experiencing a patient who has mechanical stability and or cord compression, and neurologic compromise, the standard should be that these patients should be evaluated and taken to surgery, and then followed by external beam radiation treatment. This is detailed nicely in the classic Patchell trial, and from this, surgery itself can improve overall time to ambulation and ambulation-free survival compared to doing conventional external beam radiation treatment by itself, and should always be considered. Surgery should always be considered for these individuals where at all possible. Now, local control rates with conventional radiotherapy. This is something that, again, 20, 30 years ago, 40 years ago, this was not a problem using conventional radiation treatment. With this radiation treatment to the spine, it was very conformal, but obviously our cord tolerance had to be met. Local control can be poor, however, particularly with conventional external beam radiation treatment in the absence of surgery, where progressions can occur in about 7% of patients at 1 year. For those who experience metastatectomy, followed by conventional external beam radiation treatment, your control rates were a little bit better. So again, is this a bit of nihilism versus optimism? Again, back in the day, 30, 40 years ago, we didn't have great systemic treatments. And so many of our patients would be dying from this. And so, the goal was palliation, get them to some kind of systemic treatment, but many of them are going to pass. However, in the 21st century, we've got such better systemic therapies now that patients are living longer. And so this kind of comes back to those patients. Hey, do we need to be more effective and treat more aggressively? And local therapy obviously plays a much more important role. So what lengths and everything do patients go? Obviously, there are many options to manage spinal disease nowadays. Obviously, surgery still plays an important role. Radiofrequency ablation, cryoablation, chemoembolization, hypofractionated radiotherapy, stereotactic body radiotherapy or SRS, and brachytherapy. Obviously, there are new clinical trials assessing these questions, and we're seeing this in the brain sphere, where we can say, hey, let's hold off on treating brain metastases. Let's see how these systemic therapies fare before we actually have to treat brain mets, especially if they're asymptomatic. So it's a bit of a balancing act. We have to take into account patient factors, the body site location, and then the technology and expertise of the team of people who are managing them. Of course, when you're looking at spine, this is something that's best managed in a multidisciplinary setting with the neurosurgeon, the radiation oncologist, the medical oncologist, the interventional radiologist. So kind of zeroing in now on spinal cord potentially low versus high grade spinal cord compression and the role of stereotactic body radiotherapy in these situations versus external beam. So this is a nomogram, or this is a pictographic nomogram of epidural spinal cord compression developed at the Memorial Sloan Kettering, and something again that we'll be discussing much greater detail when you have Dr. Bilski come and speak to your society. But how we approach this, and again, you have to have a little bit of a background in this, and in order to appreciate kind of when and where is it appropriate to use external beam stereotactic body radiotherapy versus proceeding to get care from a neurosurgeon or orthospine. So you have grade 0 or bone involvement only disease, where this is not actually compressing or touching the cord. These are considered individuals who have no epidural spinal cord compression. In contrast, you have it where the tumor now is much more advanced. It is now touching the thecal sac and or starting to compress a little bit of the thecal sac, but less than 180 degrees. These individuals are considered to have low, moderate epidural spinal cord compression. Now, when you actually go to lesions that now have much greater extent of involvement, where it's greater than 180 degrees or complete engulfing of the spinal canal, causing compression and loss of CSF, these are considered these high-grade epidural spinal cord compression, and are the worst, and usually oftentimes the ones that we need are urgent neurosurgical support. Another thing that we tend to take a look at, obviously taking into account neurologic and oncologic assessment. You take into account, again, epidural spinal cord compression, degree, low versus high, and then the radiosensitivity versus radioresistance of the tumor itself. For those that are very radiosensitive, conventional external beam radiation treatment alone is fine. For these that are radioresistant but are considered low grade, you can proceed likely to SBRT, but obviously still discuss with your surgeon. And then with these ones that are high grade, causing cord compression, like frank cord compression with symptoms, oftentimes neurosurgery is needed immediately, followed by stereotactic body radiotherapy. Again, this is another paper by Gertzten looking at favorable versus unfavorable disease and whether or not 30 grade and 10 fractions is sufficient. And with this, you can see radiosensitive versus radioresistant tumors. Again, radiosensitive being lymphomas, seminomas, myelomas, a lot of these hematologic, breast and prostate, versus much more hardier, much more challenging tumors such as renal, non-small cell GI, melanoma, sarcoma. With this, as you can imagine, radiosensitive, median duration of response and 2-year local recurrence, local control rates are much higher in contrast to those that are radioresistant. So how does this fare when you compare stereotactic body radiotherapy to by itself? And this is a treatment modality that has been developed in the past like 20 or so years. Again, stemming and building off of the successes of gamma knife stereotactic radiosurgery. Again, pioneered by neurosurgery, and then kind of adapted and modified by radiation oncology. As I pointed out before, stereotactic body radiotherapy is a type of treatment, 1 to 5 fractions of radiation treatment. And what they ended up doing in this study at Memorial Sloan Kettering was to do a single fraction course to those individuals who had high-grade epidural spinal cord compression. And with this 18 to 24 gray, median overall survival about 15 months. These patients, no myelopathy or radiculopathy was noted. They just had cord and loss of CSF engulfment, likely with just pain. And then the cause of death itself, they looked at all causes, death from progression of systemic disease, and not, of course, local failure. Histology obviously was not a factor in this local control. And what they ended up seeing was that actual local control was about 90%. And when you actually did the 24 gray versus the 18 to 23 gray, obviously dose matters. It obviously plays a role in terms of control. And the higher you can go, the better your local control. And again, this is borne out and seen by other groups. Now, with this, with doing these single fractions, this is obviously potentially very effective, the higher dose that you can go. But this is obviously quite terrifying, especially for the radiation oncologist, because with these doses, there's a certain limit that you can give to the spinal cord. And many of this is published in the literature with these single fraction courses. Because of the obvious fear and concern that radiation, even though you are trying to prevent these tumors from crushing the cord and inducing a mechanical myelopathy or radiculopathy, radiation itself, especially when given to very high doses, may actually lead to complications of myelopathy and radiculopathy. And so this is something that every radiation oncologist is extremely mindful of. And oftentimes we are willing to actually compromise on the cord itself, essentially the cord dose, in order to spare it, but in doing so may actually compromise dose to the tumor, and in doing so allow for potential disease recurrence. It's something that is a constant push-pull that we have to face. With this, various institutions have started to look at the role of multi-fraction stereotactic body radiotherapy and how this can be done to one, increase the dose that we can give to the tumor while simultaneously, again, reducing the overall dose, single fraction dose to the spine, which is usually more tolerable. There are other toxicities that we have to keep in mind: skin, muscle, and esophageal, which can be worsened following radiation treatment, especially when you pair this with systemic therapy agents. Another potential toxicity is loss of vertebral body height. And again, with those very single fraction doses, can lead to vertebral body collapse, and the higher the dose per fraction, such as you can see here, 24 gray versus 20 to 23 gray versus less than 19 gray. You can see this nice gradation down in terms of the amount of vertebral body damage and collapse. However, even if you get this, if it's caught early enough, you can consider vertebral body cement augmentation to try and help restore vertebral body height. So the argument for multifraction versus spinal SBRT, some of this is institutional dependent. Some of these that I've demonstrated here is also associated with Memorial Sloan Kettering's experience. However, various other institutions, Pittsburgh, Georgetown, MD Anderson, various others, have demonstrated that you can get away, that multifraction may in fact be better than single fraction. But again, this could be an institutional related event. So patterns of failure, as I pointed out before, is usually along the spine, particularly where we're cheating as radiation oncologists to try and spare the spinal cord, spinal canal, to try and reduce the risk of radiation-induced myelopathy. And so this is something that we need to keep in mind. But the other thing that has also helped us with improving our ability to give very ablative doses is the introduction of spinal separation surgery, something that my colleague Dr. Chauhan and I did quite a bit of, and I continue to do now at the University of Kansas with my new surgical colleagues. And I think it's something that's becoming much more prevalent. And I think, again, I will leave this topic to Dr. Bilski and others who will be speaking on this in more detail in future discussions. But simply to discuss briefly the Chang paper, again, a phase 1/2 multi-fraction SBRT spine study where they looked at 63 patients, gave either 30 gray and 5 fractions, considered in nowadays really a low dose hypofractionated course versus a 27 gray and 3 fractions, considered more of a high dose multi-fraction course, to intact spine or the post-op spine. With this, fortunately, they saw Their grade 3 toxicities really was dysphagia, chest wall pain, and nausea. No neurologic issues, thankfully. 1-year local control rates of about 85%, and 1-year overall survival about 70%. Again, where pain control itself was actually quite effective, as we've shown with conventional external beam. SBRT does a very similarly good job of reducing pain, and as you can see, oftentimes within a much shorter period of time. Much of these things were with conventional was noted in 1 to 3 months. This, you can see that you have a very significant pain reduction within 4 weeks. Where many of these lesions did eventually fail, usually along the epidural space and posterior vertebral body, areas where we as radiation oncologists again cheat to try and help with sparing spinal canal and cord. For those individuals who are doing stereotactic body radiotherapy to the intact spine, I would refer you to this consensus statement study by Cox for doing SBRT and how we would plan our radiation treatment volumes. Obviously, not something that one should do. I guess say in a non-standard fashion, but something that can at least help the radiation oncologist, and one that I use routinely. Another paper that I will discuss, the Lofer paper regarding post-op adjuvant radiotherapy. Again, a retrospective study, separation surgery, 7.6 months of median follow-up. And again, a majority of these patients had high-grade epidural spinal cord compression. Many had radio-resistant histologies, and many had failed prior 50% had failed radiation treatment. So with the SRS itself, strategies that they used: single fraction, 24 gray, high dose hypofractionated, as I mentioned before, the 8 to 10 gray in times 3 fractions, and the low dose hypofractionated, 6 gray times 5. Patient characteristics, as you can see, total, those that had local progression versus those who did not. But when you actually look at the rates of control themselves, you can see with the low dose hypofractionated, local failure at 1 year was 22%, 23%. So again, functional, useful, but again, not as effective as a single fraction dose, which is a local failure rates of around 9%. But when you actually look at the high dose hypofractionated, again, 8 to 10 gray in 3 times 3 fractions, local failure rates are about 4.1%. And as of date, many of my colleagues, and including myself, tend to try and use this dose fractionation, somewhere 8 to 10 gray. My preference, usually 9 to 10 gray per fraction times 3, which we think is quite effective. Now, in these post-operative settings, development of consensus statement, again, highly recommend this for those individuals who are doing post-operative stereotactic body radiotherapy in these settings. So in summary of these trials that we discussed, patients who are appropriate for surgical stabilization, followed by conventional radiation treatment, or SBRT, have superior outcomes compared to those who just do conventional radiation treatment alone. For those individuals who are high performance status patients with oligometastatic disease, stereotactic body radiotherapy can be employed with excellent outcomes for both pain control, either upfront or in the post-operative setting. So kind of integrating all of this together, individuals who have short expected lifespans, widely disseminated disease, no systemic therapy options, poor performance status, breast, prostate histology, or lymphoma, myeloma, which in some ways this is good, obviously these are bad, and who have low risk epidural spinal cord compression, you can consider radiation only up front. Situations where surgery plus radiation therapy or SBRT is probably going to be best. Patients who have good performance status, non-breast prostate histology, oligometastatic disease, good performance status, long expected lifespan, particularly those who have high risk epidural spinal cord compression and or neuropathic symptoms that would drive one to needing surgical evaluation intervention. And so with this, I have some cases that we can discuss, but I'll stop there and kind of entertain questions. And as we have time, we can kind of use some of those cases themselves if people are interested.
Thank you, sir. Excellent talk. Amazing. Dr. Chuma, I would like to ask you if you would like to comment or add something.
Greg, thank you so much for really a very comprehensive overview, and you really covered a lot of ground. I'm
My
actually
pleasure.
quite surprised at the depth of your experience. And the first question that comes to my mind, and I really have just a couple of questions rather than any comments, um, is are you seeing most of your patients from a very thriving oncology practice in your center? Um, and is that the reason that you have such a depth of experience? And well, let me ask that question first, and then I'll come to my second one.
Yeah, no. Part of this, I think, is a little bit of what of what I treat. I think at the University of Kansas and everything, we're fortunate in the sense that we're able to subspecialize, and so I treat a lot of head and neck and a lot of lung cancer. I do, and unfortunately with lung cancer, because it's so prevalent, not just in the United States but everywhere. We see a lot of these metastases that will obviously go to the spine, to the brain, but as well as that, I'm part of my experiences, and part of what I've been tasked to do at the University of Kansas is to help with designing management for oligometastatic disease. So many of my colleagues recognize my background, and so therefore specifically earmark patients to me, particularly with spine. And so this is something that I've had a lot of, obviously something I, training back in Colorado, but then I was very fortunate in New Mexico to have someone with Dr. Chauhan's background and expertise that I could partner with. And from that, we were fortunately able to build a comprehensive spinal neurosurgery, radiosurgery program, which again, to the credit and everything that of some of the things that Dr. Chauhan and I were able to kind of build together. We were able to then, I was able to port this to the University of Kansas. Unfortunately, I had many similar-minded colleagues who trained from around the country, and with this, we are on average seeing, again, still a good number of these spinal radiosurgery cases that sometimes need neurosurgical intervention up front, to those who have very no or low epidural spinal cord compression, that they're just like, hey, treat with SBRT, please. And so it's a good discussion, and it's one that fortunately, unfortunately, based on my area of expertise now, I get sent quite a few of these patients.
Okay, and my second question, Greg, is how much, perhaps Umar Chauhan would like to address this, how much in your practice has vertebroplasty combined with your therapies come into play? Is that something that's been growing over time, or has it not really become important?
Yeah, no, but that's a good question. Everything we've seen in everything that vertebroplasty has definitely come more into our practice. I would say the question of whether or not one would do it prophylactically versus reactively has begun to slowly shift with time. As the group, I'm sure, is aware and everything like that, vertebroplasty itself, there was a study in the past and everything trying to ask whether or not one could prophylactically perform vertebroplasty to try and help with improving pain and everything following radiation treatment. This was not very effective. Well, it's not that it wasn't effective. It just didn't demonstrate an advantage. And so I think certain centers have kind of adopted this. And one of the authors, Kristen Redmond, who's at Johns Hopkins, I've spoken to her about this. And so she herself, when she has concerns and everything, and particularly with a very bad lesion that may potentially collapse, and there's a concern. And again, no neurosurgical compromise at the time, but kind of on the back end, we're all thinking to ourselves like, wow, this bone is in a bad location. It could potentially collapse. Let's consider, after we ablate this, kill the tumor, prophylactically doing it. So I think it's more of a gestalt rather than an actual hard-based evidence. So I would say that over time, we have begun to migrate, despite having good level 1 evidence, to say, hey, everybody should be prophylactically treated in this fashion. I think individual groups are just using their own personal experience. Again, if it can be done safely and effectively, and I myself for a highly functional 94-year-old woman who who is very very functional. She still is doing yoga, calisthenics. She had an L3 spinal lesion, and even though it was not compressing and there was no mechanical instability, obviously she valued functional mobility. I SBRT'd that lesion, and then she herself was very well read and said, hey, I still want to get vertebroplasty, and I had her meet with our interventionalist, and they just risks and went about it, and still doing yoga, surprisingly.
Right, great. Yeah, Greg, I want to just thank you on behalf of everybody for sharing your time with us at a later. Thank you so much.
Thank you, Dr.
Dr. Back to you.
All right, sir. Thank you. Dr. Atsar, you have any question or comments, please?
Yeah, thank you. So first of all, this was just a very comprehensive and wonderful talk, Greg. Thank you very much. And I think instead of me asking questions, there are some few questions actually coming from Dr. Sumera, but Dr. Sumera is a uniquely qualified medical oncologist and radiation oncologist working in the cancer center of Pakistan, which is Shaukat Khanum Hospital. So Sumera, why don't you turn your video on, and I don't know if you know Greg or not, so but turn your video on, just ask that question.
Yeah. I saw your question, sir. Sorry, I apologize. My
it's not a sir, it's a ma'am.
It's a ma'am.
Sumera, are you there?
Yes, I'm there. Yes, I'm here.
Oh, I'm sorry,
Sumera.
Sumera. I didn't mean to put you on the spot. You might not be ready for. That's a mistake I made. You don't have to.
No, I saw your question in the chat. This is the
but you can ask your question
paper that I would recommend and everything. I absolutely agree and everything. I think post-operative spinal radiosurgery can be very challenging, and so this one provides at least for the radiation oncologist contouring guidelines. But I think something that is of strong value. When actually doing this in just as a simple case and everything, that when you're doing low grade that actually does not have true spinal cord compression or involvement, I tend to utilize an MRI spine and everything like that. So with this and everything like that, I will oftentimes combine both the combination of the axial T1 post-con as well as the T2. And from this, I would obviously work with my dosimetrist and physicist to try and do as much of a direct alignment as possible to try and contour out the true cord. And then from that, again, it's an approximation. We would obviously create additional structures to kind of help with ballooning out what we would say is a safety tolerance margin. And from that, planar radiotherapy treatment. I think with this, a good surrogate could be the canal, and with this, there's a little bit more liberalness about what your true constraint or dose constraints are. And from this, I've utilized a variety of different ones, and again, for the radiation oncologist who's probably familiar, such things such as TG101, as well as established protocols that are looking at spinal or the SBRT. And with this, I would refer to protocols such as NRG BR001, 002, which has very good spinal cord constraints as well. For the high grade epidural spinal cord compression, for these patients, for this case here, you can see that T3 vertebral body gross compression, and along with that, you can see within the canal that the canal itself is completely effaced with tumor. And so this was another case that I was able to do with Dr. Chauhan. And so here he'd gone in, stabilized the spine above and below to create this frame, and then as well debulked so much of the tumor off of the spinal cord itself. In doing so, we then 10 days afterwards, and I think this is where for again a large advantage for the radiation oncologist, if you can do a CT myelogram, you can then highlight the actual fecal sac itself, and with this you can see the cord itself floating within the CSF, and then this gives you your real time cord constraint. And if at all possible, you do the CT myelogram in the hospital, and then immediately, like literally on the very last day of them in the hospital. And again, working with your neurosurgeon, if this is if the patient is tolerable and safe and ready to actually be not instrumented, but essentially have this procedure done, you know, do the CT myelogram, inject your contrast, and then bring them down to radiation oncology to have them scanned or simulated. And from this, you can see, again, you can see the lesion itself, which has not been removed, which again, in the old days, you would do a very extensive, you know, corpectomy. Again, very morbid, can be very challenging, and the patient again can have other complicating factors and longer time to heal and longer operating time. With the spinal separation surgery, you're primarily removing the disease that's directly compressing the cord, restoring the natural kind of size and shape of the thecal sac. And then from this will allow the radiation oncologist to perform a very aggressive radiotherapeutic approach to kind of help with treating this and while sparing the spinal cord. And so this is what we're able to do here. These are some of my radiation volumes that I use to help with contouring. I was then able to treat this lesion, originally prescribed to 24 gray, but really prescribed to the 85% isodose line. So it's a bit hotter, a bit tighter. This is using multi-static IMRT beams. And with this, we're able to control this lesion. I was actually quite pleased that, again, the patient itself did not have any disease progression at the time, no myelitis, thankfully. But you know, the patient themselves eventually said, you know what, I'm not interested in systemic therapy. I really don't want anything. And so the patient continued on for another 3-4 months after, you know, discontinuing any treatments. And you know, I called in to check on the family. Unfortunately, they were still doing well. No neurologic complications or issues, and was actually ambulating to some degree, you know, despite their cancer burden. So this is how I would probably recommend and everything like that in the post-operative setting, kind of that timeline and everything. Obviously, getting your MRI total spine to help. Obviously, working with your neurosurgeon, and then when safely possible, to get that CT myelogram, and then follow this up with a radiation oncology CT simulation to help you with planning.
So Greg, I'm going to just piggyback on Dr. Juma's point here. This is a good case. I couldn't remember if we did this together, but
we did actually. Yeah. I specifically, I was like, oh, I could actually throw in what I did with the current of my ortho spine, who I think is a colleague of yours, and we can chat about him later. But I was like, you know what? I'm going to show a classic case that you and I did.
So Dr. Juma had asked about vertebroplasty or kyphoplasty or cement augmentation. And you kind of alluded to vertebroplasty when it comes to preventing a insufficiency fracture in the future. But I think as a surgeon, what I have learned, and this truly, the introduction of fenestrated pedicle screws was really a game changer in this field, at least as far as I'm concerned. So you could, all these bones, even though you're treating one area or two areas of spinal cord compression, all of these bones are tumor bones. They're very soft. And, they would, in my opinion, they need some cement for even the screws to hold. So when the fenestrated screws were introduced, I am routinely now doing vertebroplasties at every single level in these patients. And I'm noting that as you are injecting cement on your AP, I mean, in a normal compression fracture, which is traumatic, you can't really push the cement all into the body without doing a kyphoplasty. But with these, you watch the cement just intercalate everywhere within the bone. And so I think even during, if the patient is undergoing separation surgery, I would highly recommend using either fenestrated screws, or before you put your pedicle screws, just inject a cc of cement under fluoro, because this would just strengthen your overall construct as well. And I think we have Dr. Altaf Ali here.
We have, sir, one question also. Sorry, yes, we have Dr.
Yeah,
Right.
let's go on with the questions.
But we can just take one or two questions because, you know, we have reached our time limit. I think Dr. Asim is asking, he's a radiation oncologist at the Khan University Hospital. Dr. Asim, would you mind to ask, please, yourself? You can unmute.
Or maybe you can, the question is very
Okay.
simple.
Yeah, so
Yeah.
Dr. Asim,
Thank you.
Dr. Asim, yes.
Yeah, thank you, Dr. Greg. Such a wonderful and comprehensive review on the role of radiation therapy for this priority in spinal. So I have actually two questions. One is actually what is particularly in the sensitive tumors the art from respective radiation point of view, like lymphoma, myeloma. If such patient presented with high-grade spinal cord compression, what would be your approach? The second question regarding the multi-level involvement of the spine. In that situation, what would be the approach in that particular scenario? And the third one is actually about the role of actually the multidisciplinary approach in addressing such complicated cases. Thank you.
Yeah. So if I recall let me repeat back at least the questions as I'm trying to answer them to make sure that I'm getting them correct. For your first question, I think you're asking about like, what do we do about things like multiple myeloma, lymphoma that may actually have high-grade epidural spinal cord compression? Am I correct?
Yes.
So with that, we would just do external beam radiation treatment only. These tend to have very high, good alpha beta ratios and are very sensitive to the effects of radiation treatment. So for us, I think we would just treat these and everything. And again, these were actively excluded in the Patchel trial as being considered favorable and so we would just treat with external beam radiation treatment. With myelomas, I've tended to go on 2 gray times 10 fractions, and for things like breast and prostate, typical 3 gray and 10 versus 20 gray and 5. Let me see. I think for your second question, I apologize. I forgot what your second question was.
I think he was asking if you have not oligometastatic disease, but polymetastatic disease. If you can talk about, how would you treat those? How many vertebral bodies can you do SBRT on?
Yeah.
Assuming that there's no surgery required and
Yeah.
the tumor is radio resistant.
Yeah, no, great question and everything. In situations like this and everything, obviously this becomes a very multidisciplinary discussion and everything like that, particularly with what systemic therapy options may be available. And so, I would essentially have this evaluation to see. I mean, oftentimes if these patients are presenting for the very first time, I tend to be much more aggressive with trying to manage their disease. In regards to the question of how many vertebral bodies I would be willing to treat with SBRT, I've treated 2 before. It's very rare that I would actually try and treat 3, only because of the fact that I think spinal cord tolerance may be exceeded. We do have certain volume limits that we try to adhere to, and so this is always always a competing factor. Usually a single vertebral body lesion, I usually don't have a problem with. 2 vertebral body lesions that may be stacked one on top of the other, I will consider. If it is like, say, multi-lesioned at different vertebral bodies, at different vertebral body levels, such as one in the thoracic, one in the lumbar, I tend to go after those in a very similar fashion. And again, with those, usually the maximum that I've tried to adhere to is usually about two contiguous vertebral bodies. So yeah, what was the third question?
I think it was the role of multidisciplinary team.
Yeah. Again, if the patient is towards end of life and not and there are no systemic treatment options available, I tend not to employ stereotactic body radiotherapy because it is extremely resource intensive and it does require quite a bit of time to plan and prepare. And I think Usually with those individuals, I try to stick to more simpler courses, whether they be 20 and 5, 8 grade times 1, just because my goal is to try and palliate their symptoms and get them home. If they are in the situation where they have impending vertebral body collapse and or are symptomatic, again, I have a very extensive discussion with them about their goals of care. If it looks like, again, they have maybe 3 to 4 months of life, I think many of us kind of recognize, is there really a role for surgery? Perhaps not. But again, this is something that I would never assume on my own. I will always engage my neurosurgical colleagues and just get their opinion, even if it's only for a quick curbside, which again, I did quite commonly with Dr. Chauhan. And so, it's always good to have that kind of discussion to hopefully, one, keep you in check, because perhaps, sometimes people may actually derive more benefit, especially if this is something that that they feel that could benefit them. But I think more often than not, if we are all in agreement, there are no systemic therapy options, and the patient is towards the end of life, the simplest is best. And so we will usually favor that, and is oftentimes important in our multidisciplinary discussions.
Okay, sir. Thank you. Dr. Altaf is here. He's a neurosurgeon at AKU. I would like to ask, sir, if he has some comments about talk, or if he wants to add something. Dr. Altaf, do you want to add something, or any suggestions, comments, questions, sir? Sir, you are muted. Sorry. Yes, sir.
Dr. Gregory, excellent talk, and all the points were relevant. I had a couple of questions. One question was from the comment of Dr. Chauhan, that we frequently face the situation when bone is quite brittle, fragile, and you face difficulty in putting the screw. So you do the kyphoplasty in same sitting, and then you put in a screw. So you do the kyphoplasty by putting the cement through the same tray, and then you put in the screw from that tray.
So I don't do kyphoplasty. I don't think these bones need kyphoplasty. I just do vertebroplasty or cement augmentation. So once I have tapped my screws and I know, I know that my track is good, I will, if I'm not using fenestrated screws, I will just inject very slowly, like 0.8 to 1 cc of hydrocet or whatever cement you use. If I'm using, more recently, I've been using fenestrated screws. So once the screws are in, I'll just inject cement under fluoro. So it just, the cement just intercalates into the entire body. So here you have to be very careful of cement embolization, because if you're not paying attention on lateral views, these tumors are very vascular, especially renal cell carcinoma, melanoma, colorectal cancer. They are very vascular, and so they will often have these venous plexuses that go directly into the pulmonary system. And so if you are injecting and you're not paying attention, you can have a cement embolization, which can be a problem. So it's just I think the benefits of doing vertebroplasty on these patients during surgery are very, very high, but you have to be careful how quickly you inject the cement, or how soupy the cement is. Sometimes, or all of the times, the rep is making the cement in the background, and if it has to be in a certain consistency and not too watery, otherwise it will embolize. So that's what I watch for.
I want to add one more point. The consistency should be, from my previous experience, what we were used to do is like to see the consistency of the cement like a toothpaste. Yeah, so if it is falling down, right. Sorry, yes, Dr. Altaf, you were saying something.
And does it help in denervation and alleviating the pain? I mean, the cement.
One has to assume because, when you do kyphoplasties in patients who have, compression fractures from trauma and they have a lot of pain, the pain goes away or is significantly improved. But remember, in these patients, they're going to get radiation if they haven't already. So, radiation itself is going to take care of some of the pain, at least as well.
Right. And I have a question from Dr.
There's one question by Dr. Hafiz about the role of SBRT in reirradiation. Do you want me to try and address that?
Yes, please. Could you repeat the question?
So the question by Dr. Let me see, by Dr. Asima Hafiz was essentially on the role of SBRT in reirradiation. So for me and everything like that, I think it's reasonably accepted by many of my other colleagues. Oftentimes following external beam radiation treatment, if you have disease that's recurring, oftentimes we would like, obviously, the more time from the sentinel external beam radiation treatment event, I think we would prefer. Obviously, there's various papers and various groups that have actually looked at conventional reirradiation. I think if you give 8 gray times 1, you could very easily follow that, many months later, even years later, with say a more durable course of 20 gray and 30 versus 30 gray and 5 fractions. 20 gray and 5 fractions versus 30 gray and 10 fractions, very easily without any concern or compromise of the cord versus doing another 8 gray times 1 if needed. In the question of doing stereotactic body radiotherapy, obviously the more time the better from that sentinel event. Oftentimes we do see patients, particularly from the community, who then get sent to our facility who have received 20 gray and 5 fractions or 30 gray and 5 and 10 fractions. And the question becomes, hey, this patient's renal cell has recurred, this patient's breast cancer has recurred, non-small cell lung cancer has recurred in this exact location. And in those situations, again, we would have a discussion, everything with a multidisciplinary team to see for appropriateness, look for mechanical instability, as well as neuropathic factors that may be affecting them. And then based on that, we would consider using if there's no surgery to be performed. Again, MRI total, of course, an MRI total spine would have already been performed, and we would consider stereotactic body radiotherapy. And oftentimes, how I will kind of work back in terms of what radiation dose I can conceivably give is driven off of, again, various papers that have been published, and so I'm happy to share those. The other thing too is kind of quick idea is the Key and Ang macaque monkey spinal cord recovery models that we use. Oftentimes we consider at 1 year about 40-50% spinal cord recovery from conventional radiation treatment. When you get to about 2 years, you're looking somewhere around 80%, and by the time you get to 3 years, you're about almost full cord recovery, where you can give conventional re-radiation. It's based on that we extrapolate from. Obviously not perfect, but again, there are other papers that have looked at this. That I would be happy to forward along.
Thank you, sir.
This is
Dr. Chauhan. Sorry. Yeah.
Go ahead.
Sorry,
this is a very lively discussion. We have taken a lot of time, and we are actually over time. But I don't want to stop. So if there are other questions,
I'm very happy to keep going for if there are additional questions. I'll probably have to jump off in about 12 minutes or so, because actually I have a grant meeting of all things on a Saturday. So otherwise I would be more than happy to just sit and just chat and everything and discuss other cases. So yeah, no, if there are other cases or questions, please feel free. I'm happy to try and answer as much as I can.
So, Dr. Chauhan, if with your request, I think we can wrap up now, because that was an excellent session, and we can go on for long, but I think as we have reached our time. What do you think? Can you?
Yeah, I think that's good.
Do you have any closing remarks, please?
Greg, Dr. Gan, it has been such a pleasure to have you come and share your expertise with us. We know that I know for a fact that you are a star and an excellent physician all at the same time. I think given the interest from the audience and the way today's talk went, I will certainly ask you again in a few months to come back to address yet another topic. If you would kindly agree to that, that will be wonderful.
Yeah, I'd be happy to and everything like that.
Dr. Anam, do you want to say closing remarks here?
Oh no, I just will echo whatever you said, and it will be great if we can have you back again. I wanted to ask you so many questions. We'll save it for.
Thank you so much. Thank you, Dr. Gan. Thank you so much.
It's my pleasure and everything like that. Good luck and everything like that. And we'd be very happy to see all of you again sometime in the future.
Thank you so much. Thank you all. Stay tuned.
Right.
See you soon. Bye.
Omar, make sure to come and visit. We have great food here, man.
I know. Will do.
So next time when I ask, I know that there's a state between Kansas and Mississippi or not, right?
Yeah.
I think it's Arkansas.
I think it's Arkansas. I think it's Arkansas.
If Kansas and Mississippi are next to each other, my God, look at this.
Yeah, Texas, Mississippi, 6 hours drive. That's it. Yeah, to Houston and Dallas.
So it's not too bad.
All right. Take care, guys.
Take care, everybody.
Take care.